for us, I think the biggest challenge is not the recovering. It's actually making sure that we recover at a pace that is sustainable, but actually is equitable across the population that we serve, rather than having disadvantaged particular areas.
Hello and welcome to the 6th episode of our In Conversation With series, a program of monthly videos, podcasts and transcripts designed to give you the opportunity to hear directly from those influencing our NHS, whilst you either out on a walk, enjoying the coffee, or simply taking a few moments away from your emails. I'm Ed Leonardo, I'm the Business Development Manager for Liaison Workforce. Today I'll be talking to Darryn, Allcorn, the Chief Nurse at the Devon Clinical Commissioning Group and Devon Integrated Care System. We'll be discussing system working and collaboration, looking at the biggest challenges and successes so far, as well as what more could be done to help enable it. I started by asking Darryn what his experience has been so far of transitioning to system working.
Yeah, system working is absolutely key in everything that we do. And I think, if I'm honest, what we saw during the pandemic and during COVID is that systems became absolute paramount and actually became the very best of working. Mm-hmm. I think the biggest challenge is particularly in the NHS and local authorities is the number of entities, obviously with statutory responsibilities and statutory requirements coming together. So if we look at Devon, we've got 4 acute organisations, we've got 2 mental health providers, 3 local authorities, so quite a complex system. Mm-hmm. And actually, at the end of the day, we need to start thinking about patients and populations rather than organisations. So the real successes are when you start looking at pathways. So if you start looking at COVID, is probably a good example of that. But when we start looking at sort of long-term conditions, it's about how we stop the lanyard working. So the fact that that there's 5 different organisations, including the charities, local voluntary groups, those sorts of things, working together. So we stop thinking about the lanyard and actually start thinking about the person at the centre of this, because actually that person doesn't care whether I'm employed by Northern Devon Healthcare Trust or University Hospitals Plymouth or Live Well or Devon Partnership Trust. I care that I get the services that I need, where I need them, when I need them. And for me, it is very much around systems are at the best when we work collaboratively and focus around the patient journey from well-being through illness and hopefully back to recovery. And there's been some real good successes, I think, in Devon over recent times, where we've seen particularly everything from primary care through to the acute settings, through to discharge and social care, where putting the person at the heart of this, really understanding what interventions add value and what interventions don't add value, and making sure that every intervention that we do is the right intervention and adds value, and make sure that really listens to what that individual has to say and actually provide the services that they need, rather than what we think healthcare professionals and social care professionals think they need.
Mm-hmm. It's I'm completely in agreement with you there, and I think, as you said, just describing the current setup within the Devon ICS of being complex, which many other ICSs are currently, I think it'll be an ever evolving process. I don't think it's by far the end product just yet, because I think there's still a big learning curve to happen, I think.
Absolutely.
And a neighbouring system of yours, Somerset, they've when I'm looking at the recent changes that they've implemented, they're moving towards very much of a single provider with one local authority across. Then when I look at other areas of the country, you've got still some challenges overcoming exactly what you talked about, of multiple local authority entities and providers, etc. So it'll be interesting to see how those changes move forward.
Yeah, it's a very iterative process, and I think a lot of sitting behind this is around that culture of collaboration. And actually, when you start to see the benefits to collaboration, particularly on your populations that you serve, that's a real big driver for that mm-hmm. transition from entities and organizations through to system working and system deliverables.
Mm-hmm. And I think perhaps what's also ironically helped the situation has been COVID, in a way, has propelled forward that collaborative working. So there's always a silver lining to be had.
Absolutely. Yeah, we have to make sure that we retain a lot of the learning that we had in COVID, because actually COVID was, let's be frank, we never would want to be in a global pandemic ever again. But actually what it did focus was there was one common purpose. So actually that almost call to arms and that delivery around that global health emergency stop some of that silo working, stop some of the bureaucracy, really drove actually clinicians and teams to be able to be in the driving seat, so to speak, to actually really deliver that transition and do that at pace. And that's the bit that we really need to make sure that we continue to harness, because let's be frank, the individuals who are delivering that frontline care, delivering those frontline services, generally have the best ideas around how those services can improve. And if we don't harness that, then we'll always be in a position where you think, actually, we're not going to deliver that going forward.
Yeah. Obviously, on the agenda, there's a lot been said about the recovery phase and what that means. So I guess my question, really focusing on that recovery piece, is how do you think the use of virtual wards can support reduction in admissions, increase effective community-based care, and also at the same time encourage that collaborative working and better system working?
Yeah, so I think it's a really interesting challenge, and for me, the virtual wards are a really key element in terms of how we can deliver that going forward. I think, as you say, recovery is going to be really challenging, knowing the last 18 months have been exceptionally challenging, but very much focused on the here and now. And when we start looking at our elective activity, individuals that are waiting long periods of time for for elective and planned interventions, we need to make sure that every patient who is in a hospital, who needs to come to hospital, obviously has a hospital bed, but those individuals who can be cared for or supported in a different way, in a better way, in the right way for them, can be done in that way. And let's be frank, there's no bed like your own bed, and actually we need to be making sure that that is our principle. And if I'm honest, I think the virtual ward around that is absolutely pivotal in terms of delivering that, because actually it gives our clinicians confidence that individuals are monitored, that actually if the individuals start to deteriorate or start to require additional support, there's the earliest flags for those individuals, but equally that flags to the right people at the right time. It's around how we make sure that, again, as I say, community services, particularly in some of our rural areas, it's multifaceted. It's not just multidisciplinary. It is multi-professional and multi-agency. So from that point of view, what we are then seeing wider in things is actually having a system that is visible to that multidisciplinary team, but also across agencies, enables the right person. And I think what we also want to try and stop is suddenly virtual wards shouldn't really be hospitals at home, because actually that's the other risk, is suddenly if you've got that hospital at home, you've got 10, 15 individuals starting to wrap around that person, and that's absolutely right to have. But actually, that person needs to almost have that one key point. That's the right person for that particular time, not the 10 or 15 people. So I think, what we see with the virtual wards is it actually becomes a far more effective and a far more efficient model, because actually what you then see is the right person at the right time can intervene and can support, right, and then gives the confidence of the other services that are in the background, monitoring, supporting and holding, not having to get involved at that particular time in terms of a visit to the home, those sorts of things. So I think, for me, that virtual ward element, not only helps and prevents inappropriate in terms of admissions, what it also does is will actually help people to be discharged sooner, because actually the ability to monitor effectively and give particularly the acute side of our services the confidence that if they discharge that person, I won't say a few days early, but discharge those individuals when maybe medically they're not as stable as that individual would like, can go home, because actually that's probably where the person wants to be, but they can go home because actually we've got a virtual ward that is able to give us the data, be able to have it in one place, be able to inform that multidisciplinary conversation, and give us the assurance that those individuals are safe in their own home.
Yeah, it would be very interesting to see how it gets adopted across the NHS, and especially since the NHS England has allocated elective accelerators programs nationally, which Devon ICS is part of that as well.
Absolutely.
So it'll be very, very interesting to see. On that theme of recovery phase, I guess for you locally, what do you see as the biggest obstacles in this recovery phase? And what else do you think could be done to support the systems in the wider recovery phase?
The biggest challenges in terms of the recovery stage for us is inequity. We've got, again, we've got 4 acute organisations, we've got our community services. So actually, in terms of that recovery stage, what we've got to make sure is that every part of our system can recover at the same pace, because there's no point in thinking actually suddenly one part of our area is recovering quicker. So actually the service is great for that part of the area, because actually they're getting the right service in a more timely manner than maybe other areas. So for us, I think the biggest challenge is not the recovering, it's actually making sure that we recover at a pace that is sustainable, but actually is equitable across the population that we serve, rather than having disadvantaged particular areas. And by doing that, or by looking at that particular area, but ensuring that equity, then actually that makes sure that what we need is more visibility as a system. So at the moment, we've got visibility. Each provider will have visibility of their challenges, each visibility of their own recovery plans, and whether they're on plan, off plan. And I think as a system, we need to start thinking about the challenges around, actually, if one area is recovering quicker than other areas, it's actually not how we slow that pace down, but actually how we use some of that capacity to help other parts of the system in Devon to recover at the same particular pace, so that individuals who are clearly waiting for treatment are treated in a timely manner based on their clinical need, but also making sure that at the same time we can still manage the acute elements, we can still manage the emergencies, those elements, still make sure the individuals are supported in their own home. So for me, it's about having that system visibility of our entire challenges, and actually then having the conversations around doing the right thing for the population of Devon, not just the localities.
Yeah, absolutely. Thinking about collaboration that we touched on, what more do you think should be done to further enable collaborative working to achieve that multidisciplinary team element that we've also touched upon?
So that whole multidisciplinary working, and it's that prevention of lanyard working is absolutely key going forward. The workforce we've got today is the workforce we're going to have for years to come, if I'm brutally honest. We know that we've got more nurses coming in, we know that there's more doctors being trained, but actually that pipeline takes a long time. So we absolutely have to make sure that the workforce we've got today, one, is valued, one, their well-being is supported, but ultimately on top of that is that we're using them in the most effective way that we can to support individuals. So I think again, it's about making sure that we've got the tools, we've got the visibility, we've got the skill sets to make sure that that the right skills are in the right place. So how we develop individuals to enhance their particular skills, but also look at new models. So actually, how do we work between health and the local authority? How do we work between health and social care? How do we make sure that we value our local voluntary sector? How do we, those particular elements? And it's about making sure that we have visibility of the workforce in its widest sense. It's not all about doctors and nurses and social workers. This is about our support workers, our local communities. It's about all of those particular areas. And it's ensuring that we have the tools, but also the confidence that actually, a healthcare support worker or a local voluntary sector worker is the right person at that particular time to support that individual in their needs in terms of their demands, but have the confidence that actually the red flag can be waved, or the conversations can be happened that actually this individual is either improving or deteriorating, and actually then that the next level of service goes in. There is this real worry that actually if we continue not to collaborate, is potentially have again the parallel treatments, the parallel interventions, and actually suddenly you get, particularly in the community, 3 or 4 individuals visiting that individual, in sometimes 5, 6, 7 individuals visiting that one family or that one particular citizen. And actually it's about making sure that actually that how those 7 individuals could be 1 or 2 at that particular time, because it's become far more peripatetic, far more open. But actually this is not about multiple assessments. This is about having a plan of support that is driven by what that patient or what that citizen says that they need and says that they want, rather than actually having multi-professional conversations saying this is what we will provide from a nursing point of view, this is what we'll provide from an allied health profession, occupational health, physio point of view. So I think it is about how we have systems that make agnostic, so organisation, non-organisational centric visibility of what that plan of care, plan of support, plan of intervention is, so that we can actually make sure that we use our workforce to its best potential and its most efficient and effective model. And I think then, driven by that, I started that that answer with the elements around we need to support our staff and we need to support their well-being. But actually, if they feel that they're doing the right thing, that actually have got some time to actually sit and talk to that individual, is that value suddenly starts to become back in, and actually suddenly you start to see the value, the well-being, and all those elements from a staff support point of view come back into the mix as well.
Yeah, absolutely. I think that You hopefully would have seen some of the previous episodes. That's been quite a common topic, and recognition that, the health and well-being of staff, and, very much by my own admission at the beginning of the question, that our people, our NHS workforce, are at the core of everything that we do. So I think, I absolutely agree with you. That health and well-being element's got to go hand in hand.
The NHS and social care run on our workforce. The workforce is the high quality care. It's the interventions. It's the support at home. It's the admission to hospital. And without the workforce, we would be nothing. So actually, we absolutely have to invest and have to value our finite resource, which is our teams.
Personally, I think the biggest challenge going forward with the whole recovery phase is for the HR profession not to lose that sight of all this good progress and good work that we've now got in place with the people plan and that people focus. Not to lose sight of that, because it can easily be lost if we're not careful with that whole drive and pressure to, as you said, the recovery phase. Let's focus on recovery, but it's about making sure that you've got the balance.
And health and social care has always been historically a very pressured working environment. And I don't think anybody comes into health or social care without knowing that. I think historically, if I go back through my nursing career, there were times of the year when you knew it was always going to be busy, but actually there would be also times of the year when you would get a little bit of a breather. And if I'm honest now, with the pandemic, with summer pressures, with winter pressures, one pressure rolls into another pressure. So actually, when you're thinking about workforce resilience, it's about how that workforce resilience is now focused on the sustained rolling pressure, albeit the pressures are different. The pressures are no less now. Some of the pressures are no less in winter. And couple that with a pandemic and an aging population and all those elements. It's about actually we need to stop thinking about the seasonality of health and social care to actually the pressures are here, they're real, they're day in, day out, and it's about actually how individuals feel valued, how they feel supported, how we look after their physical and mental well-being, but also feel equipped and able to do the job that they've signed up to do, basically.
Absolutely. Yeah, indeed. We all know that the recruitment challenges in the NHS have been very well documented, particularly thinking about the nursing sector, the nursing staffing group in midwifery. What else do you think can be done or should be done to improve the nurse recruitment across the NHS? Because that's always been at the forefront of topic agenda, that obviously there's a shortage of staff in that particular staff group.
One of the biggest challenges particularly around nursing is, you could argue that no matter whatever you do in terms of recruitment, whatever you do in terms of those particular challenges, there will never be enough. And I think, you have to start looking around, yes, there is no doubt that we need to train, develop, resource and recruit more nurses, but equally it's about actually what does the multidisciplinary team look like going forward. So actually, is it not just all nurses? Actually, it's about how do we then recruit more allied health professions? Actually, how do we look at different roles? So actually, are there new graduate non-registered roles? Actually, what's the role of the support worker? Obviously, the nursing associates was a big step forward in some of those areas, really bringing different individuals into that nursing profession. Assistant practitioners, very, very, very similar. And obviously we've got the national ambitions around the 50,000 nurses, which we know that we're working really well on, and we know that those 50,000 nurses generally will be delivered within the 4-year window, so by 2023, 2024. But if I'm honest, it's about how do we ensure that the nursing supply for the future is sustainable. Obviously we rely very heavily on international recruitment at the moment, and that's in every individual is a valued member of the team. However, it's also about how we build not just reliance on international recruitment and our current domestic supplies. It's about how do we work differently with individuals who want to do an apprenticeship in nursing. How do we look at different elements around individuals that are choosing nursing as a career later in life, so maybe their second career, because actually their current career, it hasn't worked out, or actually they've decided that actually they want to do something different. How do we support individuals who have now got young families that want to come into a caring profession, caring vocation? So I think for us it's about having the foresight around how do we have a development program that leads potentially to a number of careers. So that could be a support worker through to a nursing associate, which are all valued roles, into registered nurse, and then on to advanced clinical practice and all those particular elements. So it's about that defined career pathway, but actually making sure that that's a career pathway generally without barriers, because actually individuals with life skills, individuals with caring skills from other areas are exactly the individuals that we want to come into nursing, we want to come into the allied health professions. And it's about how we make that easy, how we bring the development and the training of those individuals as close to the point of care as possible. So Devon, we are well served by a number of universities, which is great, and actually we've got great relationships with those universities, but actually a number of our services are a long distance away from the campuses. So it's about how do we bring that development, that training as close as possible to our places of care, so that actually the 50% time that's actually developed and delivered in practice becomes that paramount, and actually the training and the development and the academic side is wrapped around the clinical practice side of things. How do we develop, particularly as individuals, around apprenticeships, so individuals that may not be able to afford to go and take 3 years out and go into university. So it's about actually having opportunities for every individual who wants to become a nurse, who wants to become an allied health profession. There is an option for them to join that program to meet their fruition. And then once those individuals are with us, it's about how they feel valued. It's about how we continue to develop them to work to their full license. What's their next career step in terms of speciality, in terms of advanced clinical practice? Because it's great that we'll see more individuals join the nursing profession, because that's exactly what we need. But also we need to stop the attrition. So we need to make sure that individuals feel valued and feel retained, because actually, if we're filling that bath up with new individuals, but actually they can leave quicker because actually we're not valuing, we're not supporting, we're not developing, it absolutely is just as key as bringing more nurses in. It's also what we saw in COVID is individuals who, for many reasons, chose to either give their registration up or leave the profession, started to come back as a sense of purpose, because actually because of that global health emergency. It's about making sure those individuals now stay with us, because actually they've in the main have had a positive experience during the pandemic. It's around understanding why they left in the first place and make sure that we don't fall into those pitfalls again.
Yeah, indeed. And that will be the interesting phase, which is what do we do to retain them from then on? Because as I said, the attrition rate is also something that unfortunately has been at a level that in the past it hasn't been the greatest, so it's been quite high. So it's, what do you think could be done certainly from an employer brand perspective? Do you think that should be kept at obviously with the system? Do you think there should be an employer brand at system level? Do you think there should be an employer brand at the provider level with an affiliation to the system? It'll be interesting to get your view on that.
So I think if I'm true to the perspective or the principles of an integrated care system, is the brand needs to be the system, because suddenly if you have a brand at provider or individual employer level with nod to the system, is all you're doing is recreating the silos of providers. And if we're true around the continuum of the patient journey, that brand needs to be the system. But I suppose for me, it goes wider than the brand. It goes actually into what are the principles, what do we want individuals to be, as in patients, as in citizens, as in service users, what do we want them to know the integrated care system in Devon or any integrated care system to be, and I suppose it's about then and guarantee, if we meet those needs, or if we meet that those understandings, is that would add huge value to individual healthcare professionals or social care professionals, because actually no one comes to work to do a bad job. Everyone wants to come and do the right thing. People join health and social care for those principles of being able to have an impact. And I think there's nothing worse than going home at the end of the day and thinking, that's a 12-hour shift that I've not really stopped for a break and I've not really had an impact. And it's about how we make sure that individuals feel valued, but actually feel that actually it's a system that is listening to them and actually being able to provide a high quality service that gives them time to interact, listen, and almost deliver on a level that gives those individuals that worth. And I think if we do that adds value and gives real job satisfaction, but actually makes it a much more efficient and a much more effective service, because actually we are focusing on the absolute needs and the absolute desires of what people want and what individuals need from us.
Darryn, thank you very much for taking the time to be part of the In Conversation with series today. I thoroughly enjoyed myself. I think we've covered a lot of interesting topics during today's chat.
Likewise, Ed, really appreciate your time this morning, and it's been a real privilege to talk about some of the challenges and some of the opportunities that we've been facing as a system.
On behalf of everyone at Liaison Workforce, I'd like to thank Darryn for giving his time to be part of the In Conversation With series. If you yourself would like to continue this conversation, please do get in touch via the website or using the email address you see on the screen currently. We'd love to hear if you think that anything was missed, but also, most importantly, know what questions you'd like us to put forward to our NHS leaders. And also, if you'd like to be part of this In Conversation With series, do get in touch too. Thank you for listening.